So it is my pleasure to introduce today's distinguished speaker, Dr. Joseph Kim. Dr. Kim is a clinical neuropsychologist with a keen interest in the assessment and treatment of adults with executive dysfunction. He serves as an associate psychologist at Brigham and Women's Hospital and holds a faculty position in neurology within the Division of Cognitive and Behavioral Neurology at Harvard Medical School. In his clinical practice, Dr. Kim is dedicated to conducting comprehensive neuropsychological assessment for patients experiencing memory and cognitive challenges. Additionally, he provides evidence-based therapeutic interventions such as cognitive behavioral therapy and goal management training to help clients manage their functional difficulties in daily life effectively. So please join me in warmly welcoming Dr. Joseph Kim.
Thank you so much, Dr. Lee, for that kind introduction. It is my pleasure and privilege to lead this presentation on evidence-based assessment and treatment of adult ADHD. I saw Dr. Patrick Oh's presentation a couple weeks ago and was fantastic, and I think it's a great continuation of our discussion given your exposure to childhood adolescence ADHD issues. And today we're talking about adult ADHD, so you get a kind of a rounded experience here. Before I begin, I want to clarify a little bit that my background, even though I currently work in neurology, I had a faculty appointment and work as a psychologist in the psychiatry department before, and so I did have quite a bit of experience with ADHD, evaluation of ADHD, and treatment of ADHD in that context as well. Briefly, financial disclosure. I do not have any relevant financial conflict of interest other than that I do this for a living. I evaluate and treat adults with ADHD in my work. I want you to think about three things today as you attend this talk. I want you to think why this matters to you as a clinician and why this should matter to your clients that you see. First of all, I want you to think about how you can better understand and recognize ADHD in your clients. It's probably not too infrequent that you come across people in your practice that question, do I have ADHD? I have difficulty focusing, should I get medications? What do you think? So you may hear these questions time and again in your career. So I want you to think about how can you better understand and recognize ADHD when your clients present to you in your practice. And then number two, I want you to think about how can you use tools that I present to you today, maybe incorporate some of them to better screen and assess for ADHD. Even if you don't do a diagnostic assessment as a whole, what kind of tools can you use to better screen and better assess for ADHD when needed? And finally, I want you to take away certain tools, specifically cognitive behavioral therapy for ADHD, and components of it to better treat clients who present to your office in regards to desire to treat ADHD. So I won't talk a whole lot about the diagnostic features of ADHD because you already have a pretty good background from last time you heard Dr. Patrick Oh's talk. But briefly, I'll talk about the diagnostic criteria, symptom characteristics, and a few key epidemiological features to be aware of. So there's a lot of text here. I don't doubt that you can Google all these diagnostic criteria yourself, but what you need to know is that ADHD, or attention deficit and hyperactivity disorder, is largely currently divided into two different subcategories. So one being the inattentive symptom domain, and then the other being the hyperactive / impulsive symptom domain. Each of these symptom categories hold 9 key symptoms. For someone to be diagnosed in their adulthood, they need to have 5 or more of these symptoms in either of the 2 domains. And if they have 5 or more symptoms in both domains, then we call it the combined type. Now, notice that this is 5 or more symptoms as opposed to 6 or more, which is 16 years or younger. So in childhood and adolescence, the threshold is higher. Think of it as intuitively that this takes into account some maturity that happens as we age across the lifespan, as we age in adulthood. So fewer symptoms required, namely 5 symptoms required within each domain to meet the criteria for ADHD. Now that's the symptom count requirement. Of course, there's more. And I'm going to tell you about the basic idea of ADHD diagnostic criteria according to the DSM-5. But a few things for me to point out. In the inattentive symptom domain, adults with ADHD may struggle often with maintaining focus on tasks, organizing activities, prioritizing tasks, completing tasks on time, managing time effectively. And they often report completing tasks only at deadlines, sometimes late or not at all. And attention deficits may contribute to problems while driving, increased errors, traffic violations, and speeding. So this is something that you might hear from your clients coming in. And in the hyperactivity and impulsivity domain, first, the hyperactivity symptoms may involve something like, while not overly hyperactive like you see in childhood, adults with ADHD may feel fidgety or restless. They may also talk excessively or interrupt other people, and similar to the behaviors observed in children with ADHD. And in the impulsivity aspect of this domain, impulsivity in adults with ADHD is characterized by engaging in activities or speech with potentially serious consequences, such as prematurely ending social relationships or quitting jobs without alternatives. And impulsivity can also lead to driving errors and traffic violations too. Now, one aspect that is not covered explicitly in these 2 domains is emotion dysregulation factor, which may be an important factor to consider in your treatment of these clients with ADHD. So adults with ADHD often experience mood swings, irritability, anger outburst, low frustration tolerance, and motivational deficits. So these emotion regulation difficulties contribute to problems in managing emotions and engaging in appropriate behavior, potentially affecting work, relationships, and overall functioning. There are other aspects that ADHD impacts, like health and social problems, occupational effects, and even higher mortality rate. So those are things that are associated with ADHD too. So you could imagine that there are other aspects to how ADHD impacts one person's functioning who presents to your office. Now, globally, taking a brief look at the main diagnostic criteria of ADHD, other than those symptoms that I mentioned as the minimum threshold required, namely the 5 or more symptoms within either the inattentive or the hyperactive impulsive domain. So that is the first requirement. Now, it is not enough for someone to meet that threshold of having those symptoms. You also need to establish that these symptoms are chronic. The reason being, we understand ADHD as a neurodevelopmental disorder. So if you look at the neurodevelopmental disorder word, neuro means brain, obviously, and developmental means it starts at in one's childhood and become persistent into adulthood. What that means in terms of the diagnostic criteria is that several of the symptoms had to be present before age 12. And you might ask, what is several? Logistically, practically speaking, several means at least 3 or more symptoms that is now currently present should have been present before age 12. So that's something to think about is, were there still symptoms present before age 12? If you can definitively say that no, none of these present were convincingly present before age 12, then it's very unlikely that this person should be considered having a risk of ADHD. Now, the next two factors to consider are functional impairment and pervasiveness. So functional impairment refers to how ADHD symptoms impact one's functioning in their environment, whether it be at home, social relationships, at school or job, and other areas that meaningfully impact their normal functioning. Now, you can't say that it impacts functioning if it's a single place, because you have to meet that pervasiveness requirement. So pervasiveness is established as having functional impairment in at least 2 or more settings. So, for example, if you have frequent arguments with coworkers, it might be that you have a very stressful environment or bad coworkers, right? So it's not that if you have one environment where you have functional impairment that you will meet the requirement of ADHD. You have to have a pattern of functional impairment across at least 2 or more settings. So that's the pervasiveness and functional impairment requirement of ADHD. And finally, it is also important to establish that these ADHD symptoms that you account for are not better explained by other diagnoses. So we will talk about those diagnoses, but some common diagnoses that may be confused as causing ADHD-like symptoms could include anxiety, depression, PTSD, bipolar disorder, and traumatic brain injury, all of which can mimic symptoms of ADHD while the underlying cause may actually be different. So very important to gather a good history of the individual presenting for diagnostic evaluation to make sure that the ADHD symptoms are not better explained by these other factors. So if you are wanting to remember what's included in the diagnostic criteria for ADHD, this schematic is a good one to keep in mind. A little bit about the epidemiology. How common is ADHD? Study after study seem to suggest that about 1 in 20 individuals are affected by it, and that's across children, adolescents, and adults as well, right around 5%. In childhood and adolescence, boys do seem to have higher risk of being diagnosed with ADHD, but research have suggested that by adulthood, we get closer to 1-to-1 ratio, which likely suggests there is some cultural factor or biases present in the instruments that we use that could be driving the results. So further research is required, but there is a cultural acculturation factor that certainly contributes to the disparity in risk being higher for boys than girls early on in life. So after briefly taking a look at what is ADHD, what is adult ADHD, and how do we think about the diagnostic criteria, more practically speaking, what can you use to screen and assess? How can I effectively screen and diagnose individuals who are suspected of having ADHD? Now, a key that I want to emphasize in assessing and screening for ADHD is the importance of history taking. Even if you don't have a lot of time, making sure that you ask the right questions could go a long way in establishing whether someone has a legitimate risk of being diagnosed with ADHD. I will also show you some ADHD measures that are useful to keep in your back pocket to take out when needed, and also talk about appreciating complexity and comorbidity as well. So, when screening and assessing, the name of the game is asking the right question. So I really like this quote by Albert Einstein, who said, "If I had an hour to solve a problem and my life depended on it, I would use the first 55 minutes determining the proper questions to ask." So what should you ask? What should you ask to that client who presents to you, comes to your office and says, "I'm worried about having ADHD," or "I'm having a heck of a time concentrating these days. Do I have ADHD?" So here's a cheat sheet of suggested questions that could be useful for you to think about. If you are assessing for ADHD specifically, you should think about balancing the trick of asking a non-leading open-ended question, but while circumscribing to a diagnostically useful window of time in the client's life. So when someone tells you, "I think I have ADHD," what should you ask them next? You should always, of course, start with an open-ended question, like, "Tell me more," right? Which may be often very revealing. But digression and tangential conversations can happen, especially in ADHD, which may make your goal of keeping this an efficient process challenging. So here are some questions that I suggest to you. After having established that they currently do have attention issues or hyperactive impulsivity related symptoms, ask them, when did you start having these problems? Now, this question is very useful because it can quickly establish the timeline of when these started and how persistent they have been. Recall back to the diagnostic criteria that I showed you earlier, that ADHD, for someone to be diagnosed with ADHD, you have to establish the chronic criteria, right? Several of the symptoms should have been present before age 12. So if someone presents to you saying, "Oh yeah, I just started having problems after, I just recently, just a few months ago," and this is an adult person, you know pretty quickly that this is unlikely to be ADHD and could be related to something else, right? So asking the question of when did this start can go a long way quickly screening for the possibility that this may be ADHD or not. Now, more narrowing down more to the point of when they started having symptoms of ADHD. If you do not have a lot of time, you could have a leading question of, in elementary school, what kind of student were you? And more to the point, were you frequently called out for daydreaming, not paying attention, or what about being fidgety, restless, or overly talkative? I do want to caution you asking this kind of question because if your client has a fixed idea that they have ADHD, you might be asking a question that leads to a confirmation bias, right? So I want you to think about tactfully asking this question depending on the person. So it may be asking more of an open-ended question of, "Tell me what kind of student were you? You were in elementary school. Did you have any behavioral issues, or what kind of problems did you have? Did you struggle with anything?" Right? And then once you establish problems were present, what else you can ask is the pervasiveness question, right? So if they had trouble at school, asking about problems at home too, right? So they may say, "Oh yeah, at home I couldn't do my homework," or I was asked by my parents to do certain chores and I could never do them because I couldn't concentrate or follow through. So you may get that sense of, oh, maybe it's not just schoolwork that this individual struggled with. It's more than one setting. So asking about their functioning in school, but other contexts can be very helpful. Now, number 3 question gets at the functional impairment piece, which is a fundamentally important question to ask of any kind of mental illness, as you know, right? That's one of the two pillars of diagnosing someone with mental illness is the behavior unusual or abnormal, out of the ordinary statistically? And number two is, does this person have a lot of distress or functional impairment? So that question 3 asks, how have these symptoms adversely impacted your life? If so, where? And asking whether attention or hyperactive impulsivity problems currently make it difficult for them to function, and documenting clearly how, specifically, making it difficult to do their work on the job as effectively as they can, getting projects in college done on time, not listening in relationships and having a lot of arguments around being inconsistent. Having good examples is going to be very, very helpful for you. So when you ask these questions, always elicit examples as well, so that you can get a good sense how these symptoms are actually having a real impact on their life in an adverse way. Practically speaking, there are a few questionnaires that I do recommend, most of these freely available or cheaply available. So I will show you my favorite instruments of choice that you can consider incorporating into your practice. So the first one is the Barkley Adult ADHD Rating Scale. I like this one a lot because it really maps well onto the diagnostic criteria of the DSM-5. What I mean by that is all the questions on the questionnaire are structured such that each question maps onto one of the 18 symptoms. So when they rate on a 4-point Likert scale, you can get a sense whether these symptoms were present or not currently or in childhood. So this specific questionnaire, the Barkley Adult ADHD Rating Scale, has 4 different components. So you have the self-report of their current functioning in the past 6 months, but also in childhood between the ages of 5 and 12. And then you have an informant report revision asking about the same time frame, both the past 6 months and then ages between 5 and 12. Now, this is an example that I'm giving to you, which essentially tallied up the responses into a table format. Now, the key part to consider here is really the symptom count. Recall the primary issue with the symptoms is that you need to have 5 or more of the symptoms in either of the 2 domains, right? Remember that? So when you see the symptom count, which is essentially items endorsed as either often or very often, you count that as present, as a positive. So in this example, someone who filled out these questionnaires in self-report and informant report by the partner and the mom, this person, for example, endorsed having 5 out of the 9 inattention symptoms currently, and then 7 out of 9 hyperactive/impulsive symptoms currently. So clearly this person meet the requirement for current symptoms. And in childhood also, they look pretty high too, right? So they meet the requirement of 6 or more symptoms in childhood as well. Now notice that even though this goes above that threshold, that is not necessarily required for someone to be diagnosed with ADHD. Remember that you had to have only several symptoms present before age. It doesn't say that you had to have 6 or more symptoms necessarily. You just had to have several, and several effectively points to 3 or more symptoms. So it could have been that these were 3 out of 9 and 3 out of 9, and that would have still met the requirement here for childhood part of the self-report. Now, the other report or informant report is a little interesting to look at in this case. Because if you look at the mom's report, you see something a little bit different, right? So the ratings or symptom count for items rated often or very often are pretty low for this person. So 1 out of 9 in inattention, 0 out of 9 in hyperactivity. So clearly this mom doesn't remember seeing problems in her child. On the other hand, this client's current partner certainly sees that the individual has difficulty with inattention above the threshold currently. So 5 out of 9 is that threshold that's required to diagnose someone, and that is present. Now, you may argue who gets more weight, the mom or the self-report. I think that's where the clinical judgment could come in. In this case, I decided that I would give give this person more weight, especially because the mom also had ADHD herself. So her idea of normal or her idea of baseline could be very different from other parents who may not have attention problems themselves. So very important to take into account the context of who rated these things, and also use your best clinical judgment in reconciling differences in different informant versus self-report. So let's take a look at another example. So I just took out the symptom count from that Barkley Adult ADHD rating scale. If you look across these numbers, you see that hyperactive impulsivity symptoms meet the threshold for self-current, self-childhood, and mom childhood. So informant report this case. So this person consistently meet requirement for that hyperactive impulsivity domain. So we would feel comfortable saying that this person likely meets requirement for ADHD hyperactive / impulsive type. Of course, assuming that all other criteria are also met. So that's a brief overview of how the Barkley rating scale can be useful. I really like it because it really maps well onto the diagnostic criteria of the DSM-5. But these instruments can be kind of long to administer. And maybe you don't want to do a full assessment on the person and you don't have a lot of time. What should you use then? One that I really like is called the ASRS, the Adult ADHD Self-Report Scale. This one is freely available compared to the Barkley. Barkley, you do have to pay for the manual, which is, I think last I checked, it was $200. This one is free, also relatively short. It has 6 questions. It's a great conversation starter to use. And if you want to use something standard, you could use this as a way to structure some of the questions that you ask and keep track. Now, note that this does not directly map onto the diagnostic criteria, so you may have to do some finagling to glean from these answers or ask additional questions to see if there are factors that are not covered by these questions. Now, we talked about this instrument, the ASRS, being useful for current symptoms as a self-report current symptom scale. Now, what about the childhood symptom? If you want to get a little bit deeper and ask your clients to rate their childhood symptoms retrospectively, well, you can use the Wender Utah rating scale, which is a childhood symptom-oriented scale for adults. And they can use this item to respond to tell you about what they were like as a child. Now, good strength here, once again, this is free. You can help identify childhood symptoms associated with risk of ADHD. It is a little bit longer and again, does not directly map onto the diagnostic criteria. So you may have to look through it to glean from these answers to see if these will likely help you make a decision whether that person meets the diagnostic criteria. Now, very important to note that having questionnaires just by themselves shouldn't be sufficient, is not sufficient to diagnose someone with ADHD. All these questionnaires should be contextualized by asking questions to establish all of the questions that you could have confidence in establishing all of these different diagnostic criteria of the ADHD diagnosis. Lastly, if you are really hardcore and really want to do a good, thorough job of making sure you have as much confidence as possible diagnosing someone with ADHD, you can use the DIVA-5. So this is called the DIVA-5. It's a diagnostic interview for ADHD in adults. The V is I think it's a Dutch word. This comes from Europe, actually, but it actually maps onto the DSM-5. It is not free. It is copyrighted, but it's relatively inexpensive. So I just checked today, and it's actually 10 euro. It used to be 5 euros, and I think then with inflation, they doubled the price, but still not too bad. And you can use this essentially to conduct a thorough diagnostic interview. And it's got a step-by-step question to ask and different boxes to use. The PDF itself has different text boxes. You can enter the examples yourself. So very, very useful tool if you want to do a thorough diagnostic interview if you suspect someone has ADHD, an adult with ADHD. Now, a big con would be that this does take a while to complete. To do a good job of doing this interview, it takes about an hour to an hour and a half. So certainly something to consider in the trade-off. As you think about screening and assessing someone for ADHD, I want you to think about the need to appreciate complexity, right? And that goes back to this diagnostic criteria right here, exclusions, that these ADHD symptoms that your clients are reporting is not better explained by other diagnoses that may be comorbid. So what are they? Depression, anxiety, and it's worth noting that these are actually a lot more common in ADHD as well. Substance use dependence, sleep disorder can actually show as severe attention issues. And you may have personal experience with that too. If you don't sleep well, you can't concentrate, right? So if you see someone with severe sleep apnea, a lot of sleep issues, that's a red flag. Comorbid sleep disorder may have to be looked more carefully to see if that's the primary cause of attention issues. Also, trauma, PTSD, traumatic brain injury, head injuries, chronic pain, all of these can impact one's attention and even other symptoms like restlessness, fidgetiness, and emotion regulation problems that you commonly see in ADHD. So appreciating the possible comorbidities is an important part of the diagnostic process. A few other things that are probably rarer to think about. These are some other things that you can see as showing up as ADHD. Seizure disorder, zoning out, hearing impairment, hormone problems, sleep apnea, drug-induced issues, head injury, kidney problems, etc. The list goes on. There are lots of issues that could impact attention. And so an important part of the diagnostic process or assessment or screening is considering what are other factors that could be masquerading as ADHD but isn't ADHD. So consider that. And that obviously includes psychiatric issues, including mood disorder, anxiety, substance use. It's worth noting these highlighted ones, especially on the top of this list. Odds ratio vary by condition, but these four on the top, roughly about 4 times more likely to be present in someone who actually has a legitimate diagnosis of ADHD too. So It is no coincidence that you will see a patient who presents with ADHD, but also have some of these issues as well. Research has also shown that there is a dosage response, which means that more severe or more number of symptoms are present for ADHD, the more comorbid disorders you tend to see with that person with ADHD. Also important to note that the rate of comorbid psychiatric disorders in adults with ADHD tends to increase with age. As people with ADHD age, the likelihood of anxiety, depression, substance use disorder, and antisocial personality disorder increases and often become more evident, while the underlying ADHD becomes less evident. So often in clinical settings, adults with ADHD are commonly diagnosed and treated for a comorbid condition, while ADHD is often unrecognized and untreated. So something for you to think about. Now, I mentioned to you earlier that my work is neuropsychology. I do consider myself a neuropsychologist. So your question naturally might be, what's the role of neuropsychology? Should I be sending my clients to neuropsych testing to establish whether they have attention problems? Now, I want to make it absolutely crystal clear that neuropsychological testing is neither necessary nor sufficient for an ADHD diagnosis. And international and national consensus, expert consensus is very clear on this. And it's worth reading these texts verbatim. There's currently insufficient evidence to warrant the use of neuropsychological testing to determine the diagnosis of ADHD or to predict impairment in major life domains. So think about that. You send someone, and that sends someone to neuropsych evaluation, and the testing comes back with completely intact attention skills on testing. What does that mean? It means nothing. Why? Because ADHD doesn't mean that person lacks attention. And I think this point was made aptly by Dr. Go in previous presentation, that ADHD can be in some ways thought of it as a misnomer, because it's not that people with ADHD don't have attention. It is that their control of attention is faulty. When they want to willfully, intentionally control their attention, this is when they have problems. So merely saying their attention looks fine on testing and thus they don't have ADHD is not an accurate statement. So neuropsychology is not the end-all be-all diagnostic tool for ADHD. However, when neuropsych assessment can be helpful are the following. Number one, when there is no reliable history, so there was no parent or informant report, and you want to establish a little more data by looking at the overall cognitive profile of the person. And if there is especially neurological complexity, so this person coming into evaluation has traumatic brain injury or PTSD or some other issues that could also be impacting attention, it may be helpful to get additional data with neuropsych assessment. And finally, if someone fakes bad, who really wants that ADHD diagnosis for some reason, may show as having less than valid performance on some of the tools that we use as neuropsychologists. So we call them performance validity measures, and depending on the provider or the neuropsychologist, they may employ and say, this person did not meet thresholds for our performance validity measure, so we cannot interpret the data. So that may be another use for neuropsych assessment. But routinely speaking, if someone presenting for ADHD evaluation does not have a complicated history, does not seem to be feigning symptoms, it's not necessary to send that person to neuropsych assessment. And I see that very often, which is very unfortunate, because I think there's a lot of misconceptions around why neuropsych should be used in ADHD. I do want to also emphasize that appreciating complexity and diversity in presentation is warranted. For example, the process of self-discovery and identity exploration, which is very common among individuals in the LGBTQI plus community, this may coincide with challenges related to attention, focus, impulsivity. And it's important to differentiate these experiences from ADHD symptoms. In studies conducted with subsamples of and convenience subsamples with at-risk populations like juvenile offenders, Black individuals were less likely to receive a diagnosis of ADHD. However, studies conducted with representative samples typically showed a higher prevalence of ADHD among Black individuals. So there may be cultural considerations here too. Studies also indicate that racial disparities when ADHD symptoms were reported by teachers. So teachers reported more symptoms among Black youths. On the contrary, Black parents were less likely to report ADHD symptoms in their children for fear of exposing them to racial discrimination. So there's a lot of interesting complexity here that you should consider by considering the client that you see as a whole person, not just, oh, is this person have ADHD or not, right? What they tell you or what other people around them tell you might be colored by expectations, fears, their cultural experience, all of it. Meta-analysis of gender effects have found some lower severity of hyperactivity, impulsivity symptoms, or all ADHD symptoms in girls than boys. And while hyperactive impulsive symptoms may be more commonly seen in boys, with inattention symptoms being less obvious and therefore less likely to be detected. So these differences may account for or may lead to the perception that females with ADHD are less impaired. And people often also respond to the same behavior of males and females in different ways due to gender-related behavioral expectations. So for example, in 2 studies where teachers were presented with ADHD-like vignettes, so stories of someone with likely ADHD symptoms, when simply varying the child's name, the person's name, and pronouns used from male to female, boys' names were more likely to be referred for additional support. So this should tell you that we, as clinicians, may also operate with certain biases as well. So consider your own biases in taking into account your practice for when you see someone with possible ADHD. Another thing in terms of age and aging, evidence suggests that ADHD symptoms tend to decline. ADHD may persist into middle and old age with a more even to female community prevalence and referral rate with increasing age. So that's something interesting to consider also. My final part of the talk, I will dedicate primarily to treatment. What tools can I use? Can you use to treat the clients with ADHD? Of course, my bias is a strong cognitive behavioral therapy lens because that's what I know and that's shown to have a strong evidence in the literature. So I want to present to you some evidence that CBT is a strong treatment for adult ADHD. I want you to also take away some practical tips on what and how to use it. I also want you to think about considering different factors when treating clients with diverse backgrounds as well. So a few things to talk about when talking about behavioral treatment of ADHD. Even though we're talking about the behavioral treatment side, I think it's worth talking about the pharmacological side or medication side because medication is still considered first-line treatment. So there has been numerous studies, numerous randomized clinical control trials to show efficacy for stimulant medications and a few other non-stimulant medications used for ADHD. So having medication adherence for people who are diagnosed with ADHD is going to be very helpful. An effect size or efficaciousness estimate for cognitive behavioral therapy specifically for ADHD appears to be on par with long-acting stimulants, but no direct comparison has been made as far as I know so far. So a few things for you to think about when having a conversation with a client who's thinking about, should I do medication? Should I do therapy? Should I do both? One thing to think about is, when should you add cognitive behavioral therapy? One, when medications are not enough. Oftentimes, what you hear anecdotally from clients, maybe I just went on stimulant medication, and while it really did help, I don't think it completely changed my life that I was expecting to see. So this is by no coincidence, right? Medications can help change your brain chemistry, but it doesn't change or help you unlearn bad habits or behaviors that have accumulated throughout one's whole life. So behavioral therapy can really have a lot of impact on that skills and strategies front. Now, if someone has prominent executive dysfunction, that's another indication to add behavioral therapy as well. Now, when should you or should a client consider cognitive behavioral therapy alone as opposed to doing medication and cognitive behavioral therapy together? Oftentimes, this is when contraindications are made because they either had issues with stimulant medications, and oftentimes what you might hear is cardiovascular effects, like heart beating too fast, or someone has heart arrhythmia, a lot of issues related to the heart. That's not by coincidence that stimulant can do that. And if someone also has a strong preference for psychotherapy versus medication, and that could also happen in childbearing women who may not really like the idea of taking stimulant medications while pregnant. Now, there hasn't been a lot of research that suggests there is long-term effect, but people might still be cautious, and that's completely valid if they prefer to do that. It's a great way to push behavioral intervention over the medication therapy that they have a lot of reservation about. Several clinical trials have shown that cognitive behavioral therapy for ADHD is effective and helpful. So when you introduce this treatment to potential clients, you can say with confidence that there is good evidence for efficaciousness on this in treating ADHD symptoms in adulthood. So really briefly, studies of cognitive behavioral therapy for adults with ADHD have shown, when comparing CBT to waitlist group and CBT to active control groups, both show superior effects of CBT for ADHD compared to waitlist and active control, meaning their symptoms have effectively improved more so than these two other control groups across multiple studies. Now, importantly, studies have also shown that CBT for adult ADHD show comparable intervention effects to behavioral treatments for children with ADHD, which is now considered well established as effective treatment. And that's often reflected in the literature. So another thing to consider is that majority of people who are not on medication also found improvement with ADHD symptoms when on CBT. Now, this strong support in the literature is reflected in the Division 12 recommendation in the American Psychological Association that suggests that CBT for ADHD has strong research support, meaning this is definitely a good evidence-based treatment for adult ADHD. One question that your clients might ask is, does ADHD medication status make a difference? So short answer is yes. One of the key evidence you can present to your potential clients is that did you know that research shows CBT helps people with ADHD beyond what they benefit from medications alone? So yes, medication adherence is important, but doing CBT for adult ADHD helps you above and beyond what medications does for you. So that should be a good way to introduce why should you do behavioral intervention when you are already being helped by ADHD medications. So now the fun part, practical tips as you think about how can I incorporate and what parts should I incorporate when I see patients with ADHD? Or, what are some specific skills that I can think about using in some of my sessions, even if I don't do a whole CBT for ADHD protocol that's 12 weeks long. So I will present to you some tips by thinking about how you can use this in individual versus group CBT context. What are some pitfalls, do's and don'ts, and what else to think about? So a few key best practices to think about as you prepare yourself and your client for CBT for ADHD. Having a good understanding of your client's history and functional impairment in their biopsychosocial model of factors is critical. So what do I mean by that? What are the things that they struggle with? What are their symptoms? But more importantly, what kind of social roles, relationships do they have? What kind of job do they have? And how are ADHD symptoms making it difficult for them to perform their job optimally? Also important to consider, do they have comorbid depression, anxiety, and how severe are they? Are these barriers to effective intervention? I will tell you that if someone has highly, severe depression or anxiety, that could certainly make benefiting from CBT for ADHD a little more difficult and challenging. So treating that first before moving your client to CBT for ADHD could be warranted to make sure that you get the best bang for your buck. Also important to discuss their experience with psychotherapy and expectations to make sure that you meet their expectations and set the right expectations on the onset. And with that, setting realistic expectations is very important. This is not going to be a cure-all. A focus is skills learning. So how much work you put into this is how much you'll get out of it. So very important to emphasize that therapy is hard work, but it's collaborative work that you will both do together. Importantly is time-limited, very structured intervention so that your client gets the idea that we have a clear timeline of learning things, even though individually you may adjust and troubleshoot along the way, which may make the duration of the whole therapy a little bit longer. There is an expectation that you have a good structure that you will follow, which also helps you get your client to anchor their expectation of how long the therapy could be, which is typically plus or minus 12 weeks if you do the whole standard manualized approach to CBT for ADHD. Now, you might ask, what are some books, what are some resources I can use to follow this manualized version of ADHD? There are a lot out on the market. I like all of these. One of my favorites is this one on the very right. It's from the Treatments That Work series, which is amazing as a whole, but it is called Mastering Your Adult ADHD by Safran and colleagues, Safran. What's good about this is it has not only the client workbook, but also therapist guide as well. So you can use a session-by-session guide to help your client work through different modules and sessions. So you can obtain the therapist workbook and you can have your client use the client workbook to follow along session by session, which is very good. A few other books to recommend. I won't mention all of them, but you should get the PDF, get this via PDF at the end of the talk. And then I mentioned to you this particular book is a favorite of mine to start out a client if they do not have any experience with CBT for ADHD. It's a good one to start out with your client. and it is essentially consistent of 12 one-hour sessions. And it has a few different components: psychoeducation, organization, and planning. So starting out with psychoeducation of what is ADHD, what is adult ADHD, and getting quickly into organizing, prioritizing, and planning, and then moving into distractibility, and then adaptive thinking, which is related to the cognitive restructuring piece that is that is at the backbone of cognitive behavioral therapy, and then applying to procrastination and relapse prevention. The previous book is a good one to use for individual sessions. This one, I think, is particularly useful for group CBT. Similarly organized in 12 sessions, a little bit, different kind of flow to it, but it has relevant parts for you to run the protocol as a group, which is going to be very helpful. I like to limit my group to about 8 to 10 people, and I have used the Zoom as a way to deliver group CBT, and I think this certainly provides convenience to a lot of people who may have difficulty in carving out time to show up physically. Of course, there are cons to making it as engaging as possible. People may not be paying attention at times. So it's very important to think about and talk about setting up ground rules and best practices, which is helping encourage your clients to keep their camera on so that you make sure that they are paying attention, etc. Now, mindfulness approaches can also be very helpful to many actually. And this manual has the added component also of emotion regulation and communication piece that is not as well covered in the other manuals. So I really like that about this book. This is the same one. This is the client one, and this is the clinician guide. So you can use this as a paired tandem book for you to follow along as a guide, and then for your client to read chapter by chapter as a treatment together. I use this one specifically often for clients who finish either the individual or group standard 12-session program. And I suggest that they do the mindfulness approach as the next step, whether it be alone or with you as a guide, session by session. And some have opted that, they feel that they can kind of tackle this on their own. So they buy this book and follow along session by session on their own. But if they desire to continue to have you as a therapist as a guide, then you can follow along with your clinician guide as well. So a few other practical tips as you get started. It's very helpful and important to model organized behavior. And some of that could include, as effortful as it may be, sending summary emails to make sure that you present yourself as an organized therapist and that they can also do something similar to this. Also very important to show that you are going to be punctual and that you expect them to be punctual. And it's very important to address some of these issues, right? Tardiness can be a problem, and it could be a symptom of ADHD. It's very important to talk about and problem solve together when these show up in sessions, that they are late constantly, what that means, and how can you help them? How can you help them prepare so that they don't repeat the same behavior? Another thing to think about, as is the case of importance of any therapy, it's very important to talk about values. So I often present to my clients that I give the how, right? How to do things better, how to be more effective, how to pay attention, how to be less distractible, how to organize. But they bring the what, and that is their value, right? So incorporating their values is just as important as they're learning the how. So getting a good understanding of the what is important in their life, the social relationship, good performance on the job, etc. That's going to be what drives your conversation as you continue your therapy with your clients. As you begin your therapy with your clients, very important to set the right realistic expectations, helping them understand that improvement is not linear like this, right? Nothing is as smooth like this. You don't see improvement that's on a continuous upward trajectory. And it's more likely something that looks like this. It'll be messy. So I often say, I often have this mantra of improvement or progress is messy. That sometimes you'll see regression, sometimes you will feel like you're not really progressing much. For the first few weeks, they may notice that they're really staying in place like this. And at some point, if they're putting in the work consistently, they will see improvements. And that's really the goal, is consistency and cumulative effect of their hard work. And the beginning sessions are important because you also address some of their misconceptions about what ADHD is and what ADHD isn't. So it's very important to educate yourself about that. And so make sure you know the diagnostic criteria, what ADHD is and isn't. There's a lot of folk knowledge about ADHD and ADHD treatment. And so if you don't know, make sure you do the research to tell your clients what is evidence-based conclusions about ADHD or how it manifests and what the treatment means to them. One common question that you may be asked pretty frequently is what causes ADHD, right? So that one I think I can answer right now is ADHD related to nature or nurture? The cop-out answer would be it's both. But in this case, ADHD has a very strong nature component, and nature being genetics. There's a lot of research on heritability of ADHD, and it's on par with other disorders that are known to have high heritability, like autism spectrum disorder, bipolar disorder, etc. So that's a lesser known part of ADHD, but ADHD does tend to run in the family, so it's not uncommon for you to see a client who presents with, oh yeah, my mom had this issue, or my dad has this issue, or I have sisters or brothers with this issue. So commonly runs in the family for the reason that it has a very strong genetic component to it. I mentioned this in passing earlier, but it's very important for you to be planned about discussing when outside session behaviors occur in session. So they may say they are inattentive, or they are distractible, or they procrastinate, and they may come to your session and say, I have not done anything since our last therapy session. I have not done my homework. What do I do, right? It's very important to acknowledge what's going on and to problem solve together. Don't ignore that. Don't just say, okay, just do it next time. Have a conversation head on. Make sure you address the fundamental issue as part of the symptom presentation, because that's what ADHD is, right? So being late to sessions, forgetting to complete work, losing things, very important to have a conversation about that and make that a part of your therapy and not just ignore it. And then making sure to emphasize that it is hard work. It's not just about learning the skills, but actually practicing consistently day after day to incorporate this as a habit. Now, what skills are actually taught? Here are some key skills, key concepts that are covered: prioritizing, organizing, problem solving, coping with distractibility, and cognitive restructuring, which is the backbone of CBT, actually. So a typical session is going to be structured as follows. So you will set the agenda. I like to tell the clients, and this is another part of this modeling of structure and order, right? You tell the client, I start every session with an agenda. Here's what I want to cover today. I want to talk about ADHD symptoms. I want to talk about organizing and planning. I want to check in with you about A, B, and C. What else do you want to add, right? So setting the agenda together, but making sure that you present to your client with a good, solid plan goes a long way. And it really models that behavior of being structured and organized to your client. And then you, as needed, may review symptoms, impairment, medication adherence as is needed and helpful if they have problems with that or have difficulty. And then you review skills, which includes talking about between session assignment. How did things go? I assigned that you do the task list or ABC task list last week on a daily basis. How did that go? Tell me how it went, right? As you need to celebrate success and problem solve difficulties. Celebrate success, problem solve difficulties. Reinforce the good parts of what they did, and then tease out and improve upon what they struggled with. And then after you do the review, which is a significant amount of time, you introduce new skills in most sessions as appropriate, and then assign between session homework. Now, starting off in the very beginning few sessions, and typically in the very first session, it is very helpful to talk about what you are going to do together. Who is going to be involved? What can they expect? Helpful to talk about family members' roles, whether they have a partner, a friend, or close family member that they can enlist for help or social accountability. Very helpful to talk about. Also, identifying behaviors that are problematic for treatment planning. So, for example, if you see a client who tends to be very chatty and talkative, you may be upfront and say, if we go on tangents, I want to make sure we have a plan. So what do you think we should do? Should we have a signal? In talking about a way to make sure that you have a non-threatening way to communicate to problem solve in the moment when the problem arises is going to be very helpful. So an example could be, I had a very chatty client who would go on tangents a lot. So it was really helpful to establish a rule where if either of us notice that we're going on tangent, we will do a timeout sign so that we can recognize this and say, are we on task? Are we on topic? And if we are, then we will continue. But if not, we will pause for a moment and try to redirect our conversation to the appropriate topic. It is also important to talk about setting the right treatment goal. You can't promise that they will finish a huge project in a short period of time. You can help them say, you will learn a skill that will be useful for you to be effective in completing, parts of your project or meeting deadlines. And so setting the right expectations is an important one. And then if needed, motivational interviewing and motivational exercises to make sure that they come away in the very beginning few sessions without much ambivalence, that they are getting into therapy with confidence and anticipation of, yes, if I do the work, I will benefit from it, and I am willing to put in that work. So talking about the treatment in the beginning session, it's important to talk about the treatment as a sequential treatment so that it builds on fundamental skills and you continue to learn, so that it's very important to get the fundamentals right. So you may emphasize that if the fundamentals, like the prioritization, is not acquired easily, then you may do a few more sessions as needed. So in the same spirit, repetition, practicing on their own is necessary, is something that's very important to communicate, that the session, the therapy process doesn't end with them listening to you explain the skills, but a big part of the therapy also happens outside of the session when they practice on their own day in, day out. Also important to recognize that they may be impacted by problematic behaviors that occur outside the therapy room, and problem solving together in the session could be a topic of interest as needed. The CBT model is an important one to understand. It looks a little complicated, but I promise you it's not. So overall, you have these core psychiatric impairments that go with ADHD, but these factors, including history of their experience related to ADHD, causing dysfunctional beliefs, cognitive beliefs, which is at the center of CBT model, which may cause additional mood changes, which may also exacerbate difficulty developing and maintaining compensatory strategies, feeding back to functional impairment, and it having a negative cycle, vicious cycle, is something to talk about more than once. Because oftentimes your clients may not recognize how this can all be linked, right? They may say, oh yeah, I have ADHD symptoms and that's causing a problem. But it's more than that. ADHD symptoms over your whole lifetime have caused you to have certain dysfunctional beliefs about yourself or how you function. You may also need to address depression, anxiety, guilt, anger, and how building certain skills can really help them with the functional impairment and thus change their perception of themselves. So emphasizing that these factors are all linked and having an appropriate conversation when they arise, making sure that they are aware of these factors impacting their functioning and their symptoms is going to be a critical part of your discussion. Conceptually, you should have a conversation with your clients about giving up unhelpful strategies, right? One person, I forget where the quote comes from, but madness is defined as doing the same thing over and over, hoping that it'll produce, results, right? So making sure that we are not only about learning new skills, but also giving up unhelpful strategies, that's something important to talk about. So the very first task that you introduce is going to be organizing multiple tasks. So this one is a very fundamental task that a lot of the clients that I've seen really, really like. So it's called the ABC task list, or it's a prioritized to-do list. So what it does is essentially a upgraded version of the to-do list. So you've all done a to-do list, but essentially what you ask your clients to do is write out all the tasks that they can think of. More specific, measurable, and realistic, the better. Write them all down that they can think of, whether it's going to be something they want to do today or maybe tomorrow or by the end of the week. After having written down all the tasks, you have them assign priority rating of A, B, or C. A being the highest, most important task, something that you want to have done, have complete by the end of today. B is something that is still important and meaningful to you, but not the end of the world if you don't complete it by tomorrow or the day after. C is still important. Maybe if it's a good day, great to get to. If not, maybe I want to get it done by the end of the week, right? So different tiers of priority rating. So once you rate priority of A, B, and C for each and every task listed, very important to emphasize that they should go in order of importance. All the A's first before the B's, and all the B's first before you move on to the C's. Now, it's very important to make sure that they articulate the tasks in as specific and measurable steps as possible, and also small enough so that they can do in one sitting. So you wouldn't write something like, write the next great American novel, or finish putting in concrete in my driveway, because you can't do it in one sitting. You can't do it in just an hour or two, right? So making sure that they list out, break down tasks small enough so that that's not too overwhelming for them is an important part of helping them do this prioritized ABC task list. These are a little bit more secondary. You can have them list out due dates put on the list and dates completed for record keeping purposes. But if you want to keep it simple, having the task list and prioritized rating, and then crossing out as they go in order of priority rating is the key. When you present this skill, it's helpful to also emphasize pairing this activity with something that they're used to doing regularly, like brushing your teeth at night or morning cup of coffee, so that they can incorporate this as a habit because they're pairing with something that they already regularly do without thinking. A few other skills to mention: problem solving, breaking tasks down into manageable steps is another one that is very helpful and important. listing steps down, making sure each step is manageable, putting the steps on the ABC task list is the fundamentals of it. But there are a few more steps if you look in more detail, which is defining or articulating the problem, listing out solutions, if necessary, doing a pros and cons list, rating each solution, and choosing the best. So there are a lot of templates in many of the books that I already mentioned to you, and you can use those as a guide to help your client do this problem-solving skill. In terms of organizing module, it's very helpful to talk about physical as well as abstract things organizing. So email inbox may also be very cluttered as much as their actual table or desk or their closets. So helping them establish a good routine and hub or sorting system is going to be the critical part of this module. Coping with distractibility is something else that a lot of clients really like, which is helping them not only gauge their attention span, but also use a strategy to delay their distractible tendencies. So some of you might know the Pomodoro technique. It's very similar to that. So you measure a certain attention span and have them focus their attention for that period and repeat until they're done or completed with a single task that they intend to finish for that. Coping with distractibility is a very helpful one. Motivation is an added one from the Solanta treatment that is also important to think about. Incorporating values, talking about self-reinforcement, making sure that they can use reward as a guide. So if they complete long-term goals, they can reward themselves with something good is something important to talk about with your clients too. As you may already know, this is the basic model of CBT, right? Thoughts, feelings, behaviors are all chain linked, and that's how our thoughts may influence behaviors, feelings might influence behaviors, and they have a bidirectional connection. Now, using something like a thought journal, you can address something like procrastination. So for example, at home, thinking about doing taxes and addressing the thoughts, feelings, and ultimately coming up with adaptive thinking in replacement of these harmful automatic thoughts. And here are some examples of harmful automatic thought that you can look at. Pretty self-explanatory, but many of these are going to be helpful to talk about with your clients. And reference for these are in most of the CBT books. So you can get an explanation to them that way. It is also important to recognize overly optimistic cognitions are a type of harmful automatic thoughts, right? Harmful automatic thoughts don't necessarily have to be negative. It can be that overly optimistic leading to procrastination and avoidance of tasks. Another module to think about incorporating is application to procrastination. Sometimes these can be positive qualities for some. Many people say, oh, I thrive on procrastinating and doing it last minute. But it's also important to talk about real world consequences. Maybe you could have done a better job. Maybe you could have, had a less stressful work experience, etc. And using these skills to address specific behavior related to ADHD symptoms is going to be very helpful. In the relapse prevention, you will review the whole program, talk about what components were helpful, what areas they want to continue improving, what do they anticipate as difficulties as they move into the wild without you as a therapist doing the CBT together. And it's really helpful to talk about what will you do when problems arise? How will you continue to practice these skills? So something important to talk about as you talk about relapse prevention in your final few sessions. So we're almost out of time, but I will continue talking about review of your potential role as a clinician, as a wrap up. So in assessment, you can provide screening, may also do some aspect of diagnostic evaluations. Although most are done by psychologists or psychiatrists, you may be asked to do that. if appropriate. And you may also want to do your screening first and then refer to diagnostic evaluation or med management. So incorporating some of the tools that I mentioned to you earlier to assess and screen would be helpful in your practice. And in treatment, knowing how medication is central, but also evidence-based psychotherapy like CBT for adult ADHD is very, very helpful, can be a useful conversation to have with your clients, even if you don't intend to treat clients behaviorally with CBT. There's another approach that's called goal management training that I didn't talk about with you as much, but this is another approach that has overlapping components with CBT for ADHD, but comes from a neurological basis. So I will include that in my slide for those of you interested in some other alternative approaches as well. So there is accumulating evidence that this can also be helpful. Importantly, I think it's very helpful for you to think about how you can have a team approach of treating your clients, not just you as a clinician providing therapy or brief screening or assessment, but how can you work as a team? So emphasizing that that your clients adhere to medication treatments, emphasizing that they regularly attend therapy, but also helping them establish good psychosocial support, find resources, and build their community around how they can actively practice what is going to be helpful for them to improve upon their ADHD symptoms. Moving forward, it's going to be very helpful also for you to think about tailoring your intervention to clients as you gain more familiarity with something like CBT for ADHD. So don't be afraid to customize the intervention based on your client's needs. It's okay to modularly incorporate different aspects of ADHD. You don't have to complete the entire 12-week program. You can pick and choose what's useful for your client if you have limited time with your client. So think about what are some specific useful skills that I can pick out and take out from those interventions manuals that I can incorporate into my practice with specific clients. I already talked about the collaborative care model, so I won't repeat it here. In conclusion today, hopefully you're taking away how to better understand the nuances of ADHD in the context of clients' life by appreciating the different aspects of the diagnostic criteria of ADHD. Also, I hope that you took away some ideas on what measurement tools that you can incorporate in your practice to better assess or screen for ADHD, cater to your needs. And I also hope that you learned how CBT can be useful as a treatment, as an evidence-based treatment, as a new tool in your clinical toolbox. Thank you.